Hi, sir. Can you hear me? Neeraj, sir?
Yes, Rafi. Yes, Rafi.
Okay.
Good afternoon.
Good
Can you hear
afternoon,
me?
sir. Yeah,
Can you hear me?
I can see. Yeah, we can hear you.
Okay, good. Your visuals are not coming in. Sorry, visuals are not coming in.
Only the screen will be coming.
Oh, okay. Right.
So, shall we start, sir?
Yeah, sure. Please go ahead. You have the students list also. I didn't get the students
Yeah,
list.
I've shared it with you. Like from that, you can see the list, attendees list. We have around 40 people as of now online. We have 97 registrants. The dashboard, can you see in that the attendees list can be seen? I've shared it with you also.
Okay. How many of the attendees are students?
Like we have 97 registrants
Oh,
totally.
you don't. Okay.
All the 41 can be considered as students for this seminar.
Okay.
All the
All right.
attendees are students as of now.
Okay.
So today, welcome everyone. A very good afternoon to all. Today we'll be having a very interesting session by Dr. Neeraj sir. He's our star faculty. As you know, or some of you might be knowing, he's the professor and head of in charge of division of blood and marrow transplantation at Amrita Institute of Medical Science. He has done his MD from Trivandrum Medical College and DM from CMC Vellore in clinical hematology. His areas of interest are bone marrow transplant for malignant and non-malignant disorders, adult and pediatric leukemias, myelomas, relapsed lymphomas, hemophilia, and flow cytometry. He has over 25 publications in national and international journals. So all over to you, sir. I will be making a presenter now. You can start sharing your screen.
All right. Thank you very much, Dr. Rafi, for the kind introduction, and also it's always a pleasure and honor to participate in Cascade right from the beginning. And I always enjoyed this session of putting case scenarios for discussion. So we'll get started. Share screen. Can I operate the screen? Rafi, while they get the screen, I wanted to introduce Dr. Karthika. I don't know if you have met. You can you hear me?
You're audible. You're audible.
Yeah. I wanted to introduce Dr. Karthika to you.
Okay, sir.
Karthika is our star hematopathologist. So the cases have been kindly provided by Karthika from the coagulation lab. So my acknowledgement to the coagulation lab and Dr. Karthika before presenting the case. Okay. Is the screen shared, Rafi? Is the screen shared?
Yes, sir. We can see it.
Okay. Just let me see. Yeah, attendees. I think I'm not able to pick and choose the attendees. When I pick the attendees, the screen sharing is going off. So, Rafi, I will request your help in getting one person for a case discussion.
Okay, I'll start. If you have any first alphabet, I can just take one from that.
Right. Okay. Sure. So any one more. So
you'll have to tap on the screen and it'll go next.
Yeah. Right. Okay, so let us. I think for those who are new out here, the format, the how we are going to go about this case scenarios is that there are around 10 cases, and the initial slide will show you the case scenario, and it will be good if there is a volunteer or somebody who a named student who can discuss this case. Essentially, for each case scenario, there are two questions. What are your what is your clinical impression? Differential, clinical impression can be just that it is a congenital disorder or an acquired disorder, or whether it is a bleeding disorder at all, or is it a something else. That and then you arrive at a kind of provisional differentials, and second question on that scenario will be to answer what tests will you be doing when this case comes to you. All right. So first case is a 48-year-old female who has sustained who came with a traumatic shoulder tear, and she was planned for an arthroscopy from the orthopedics department. She was sent for a pre-anesthetic checkup, and the pre-anesthetic evaluation showed an unexpected value of APTT of 88 seconds. The clinicians have reported no past history of bleeding. She is not on any medications, and she has also a blood group of O positive. So this is the history that is given. Now I would request Rafi to name a volunteer, and then
if anybody is volunteering, you can raise your hand first. After that, if nobody raises, we will pick them out. 2 seconds for raising your hand, if anybody. Yeah, Dr. Mohammed Anas Sheikh has raised his hand, so he has volunteered. Okay.
Can you introduce yourself, Dr. Mohammed from?
Mohammed, you can unmute yourself and speak. Mohammed Anas Sheikh, please unmute yourself and speak.
Good afternoon, sir.
Good afternoon. Yes.
Sir, myself, Dr. Mohammed Anas. I am final year resident transfusion medicine from Armed Forces Medical College, Pune, sir.
Very good.
So,
okay,
sir,
Mohammed,
as from the
what do you think about the case?
Sir, there is a 40-year-old female, sir, with a hemostatic challenge in the form of a traumatic shoulder tear, sir. And on investigation, she only has isolated APTT prolongation, sir.
Okay.
And with no past history and no history of any medication, sir. So unlikely to be a inherited or a congenital bleeding disorder, sir.
Okay. So why do you think there is a bleeding disorder at all?
Sir, it could be or could not be, sir. The prolongation of APTT is not consequential in the absence of a definite history of bleeding, sir.
Okay. So do you? My question is, do you think it's a bleeding disorder for definite, or is it a suspicious bleeding disorder, or it is not a bleeding disorder?
It might not be a bleeding disorder, sir. It's only a investigation that has shown prolongation, sir. And it could be because of various factors, sir, including various pre-analytical variables also, sir, or sample processing, sir. So it can be also a false elevation of APTT, sir.
So what are the causes by which you think APTT can be prolonged without the patient having a true bleeding disorder?
Sir, it could be because of pre-analytical variables like sample processing or sample collection also, sir.
Particularly anything in the pre-analytical part which can prolong the APTT?
So sample storage or the reagent that we are using, sir.
Any medicines?
Medicine, sir, it could be because of heparin, sir, but unlikely in this case, sir, because
suppose this patient was in ICU.
So it could be because of I can't think of any particular medicine apart from heparin, sir, actually.
Heparin, yes, but yes, definitely. So heparin is a very important possibility, especially the patients in intensive units may have central lines. They may be locked with heparin, so the sample may be
Sir.
contaminated
Yes,
with
sir.
heparin. Definitely, yes. What else? What else can happen? So heparin is one important. Yeah. What else can happen in a non-bleeding patient which can prolong APTT?
It could be because of certain inhibitors like lupus inhibitors also, sir,
Very
causing
good.
isolated APTT prolongation, sir.
So lupus anticoagulant, very good. So excellent. So
Sir.
lupus anticoagulant is another reason for prolongation of APTT without an active bleeding. But I wanted to ask you one more thing. So that's very good. Very good evaluation. So can this patient be having a bleeding disorder after all? I mean, if you repeat an APTT and find out the pre-analytical error is, you have called this patient to your lab and made sure that no pre-analytical error is there, you collected everything properly, and then still the APTT is prolonged. Then I'm asking you whether the patient will still likely to have a bleeding disorder which was undiagnosed till 48 years.
Sir, unlikely, sir. In case of even minor trauma, if there is a bleeding, so that could be suspicious of a bleeding disorder, sir. But
Okay.
unlikely in an adult female of 48 years old that it could be missed, or if the factor levels are on the borderline, sir.
All right. So you're thinking about a mild factor deficiency. But do you think the APTT of 88 can occur in a mild factor deficiency?
No, sir. The normal levels are somewhere like 26
Okay.
to 40 seconds, sir.
Very
It's
good.
highly elevated, sir.
Unlikely. So how will you proceed with your workup?
Sir, we'd like to repeat the patient sample for APTT, sir.
Yeah,
And we'll do the...
We have repeated and it is still showing 80 seconds.
Sir, we'll repeat the complete screening coagulogram, sir, including CBC, and we'll do the workup for APTT, sir. We'll like to perform the mixing study, sir, to rule out any factor deficiency, sir.
Okay, I will give you some more information. The peripheral smear is normal and the PT is also normal. So you want to proceed with the mixing study APTT. The mixing study, okay, right. So, so let us see what happened to this patient. Thank you. Okay, so, okay, you have seen that the mixing study is showing an 86.5 correction. What do you think about that correction?
So the correction is almost complete, but it's not a complete like a complete correction, sir.
Yeah,
it's a partial
like
correction, sir.
Almost like a, yeah. Is it a very bad correction?
No, sir. It's a good correction, sir. I feel correction more than 80%, sir.
Okay. So we have factor 8 levels. The lab has further proceeded with the factor 8 and 9, which is the most common available. And
both
they have
appears
said
to be normal, sir.
That appears to be normal. Further on, they have done even a von Willebrand antigen. That is also normal. Now, what do you do?
Right, sir. Sir, the further workup is most likely suggestive of an inhibitor, sir, a lupus inhibitor, because the correction is not complete, sir. While the factor assay is normal, sir, both for factor 8 and 9, sir. So that rules out any.
Do you want to do any other
hemophilias.
factor assay? I wanted to ask you, before proceeding with your inhibitor, have you completed your factor assays for an isolated APTT prolongation?
No, sir. We'll like to work up for factor 10 and factor 5, sir.
It is an isolated. It is an isolated APTT prolongation. So, are you sure it is going to be factor 5 and 10 or something else? It should be factor 11 and 12, right? Hello? Hello? Hello?
Hello?
Can you hear me?
Factor 11 and 12, sir. Sir, I can
Sorry?
hear you, sir.
Yeah. So factor 11 and 12. Do you want to do 11 and 12?
Yes, sir. So I think I would do factor 11 and 12, sir.
11 and 12. So very good. So let us see what the 11 and 12 results are. Okay. So we have factor 11 of 2%.
Sir,
All right. What do you think about that?
sir,
Good.
it's low, sir. Factor levels are low, sir, for factor 11, sir.
Yeah. So where does factor 11 act actually? In the cells of, you've had your class on the cell-based model for hemostasis?
Yes, sir. It was taken in physiology
It was
of
taken.
coagulation.
Yeah. So
So,
thank you.
so
Thank you,
there is a
Rafi. So
disturbance in the audio, sir. I can't make out what you're saying, sir.
can you hear me now? Can you
Sir,
hear
I
me
can
now?
hear you, sir.
Okay.
So there is a echo, sir. Echo in the audio, sir.
Let me remove my mask and see. Can you hear me now? Can you hear me?
No, sir. I can't still make out what you are saying, sir.
So I think it's his problem because we are all hearing. It's clear for us.
Okay, sure. Okay. Yeah. All right, Rafi. So I'll proceed with see basically why thank you, Dr. Mohammed. See, basic the, reason for presenting this case was factor 11 deficiency is a rare cause of isolated APTT prolongation, and often the patients are asymptomatic because we haven't still yet really understood the role of factor 11 in the hemostasis. We know that in the amplification where the thrombin is generated and factor 11 is activated to factor 11A, and it is believed that in 50% of the patients it is involved in the hemostasis, and in 50% of the patient it is probably not involved in the hemostasis. So the factor 11 is a unclear area. If this patient wants to go for a surgical repair of the shoulder joint, what would be the strategy? Would you transfuse, or would you? Anybody can answer that.
Sorry, where is your phone?
Would you transfuse? Would you transfuse factor 11? Rafi, can you hear?
Unmuted, so they can talk. Anas?
Yeah.
Or Merlin also has, Dr. Merlin Augustine.
Yeah. So I will tell the answer. Okay, if I see basically, the factor 11 role in hemostasis is not very well understood, but we would expect that it has some role. Unlike factor 12, where we know there is no role in hemostasis. So in this patient, if she is going for a surgical replacement, I would replace with the factor concentrate if it is available. If not, at least with a fresh frozen plasma replacement would be advisable prior to going for a surgical procedure. Okay, right. Shall I move on to the second case, Rafi, now?
Yes, sir. Any volunteers for the second one? You can raise your hand. Dr. Deep Matkaikar, I have unmuted you. You can go ahead. Dr.
Yeah,
Deep.
So Dr. Deep, while you can introduce yourself, I'll just introduce the case for you and the audience. It's a 47-year-old female with increased perioperative bleeding, and after the she required readmission and resuturing, and required plasma transfusion for the ovarian removal, and she also had a mother who had a history of menorrhagia and melena, and she had blood group of A negative, and initial screening investigations revealed a thrombocytopenia with a normal PT and APTT. So Dr. Deep,
Hello, good afternoon, sir.
yeah, Dr. Deep, yeah.
Yeah. So, according to the case history that is provided, there is basically a normal PT and APTT. So, coagulation screen is normal. Okay, and multiple previous bleeding challenges, such as that is since childhood, from tooth extraction, then even for ovarian cyst removal, she required plasma transfusions, and it's basically pointing towards either a platelet or a vessel wall disorder. And since the mother also had history of menorrhagia and melena, it's pointing towards a variant of Wall-Willebrand disease, and that is most likely to be type 2N, that is associated with thrombocytopenia in patients. That's what I feel according to me. Hello. Hello.
What subtype?
Hello.
Sorry.
Uh, can you hear me?
Yeah, I can hear you now.
Okay. So I'm suspecting a variant of von Willebrand disease in the patient, most likely type 2N, that is associated with thrombocytopenia.
So how do you want to proceed with the investigations?
Um, so investigations, she has already undergone an initial screen. The complete blood count is done, so that is showing thrombocytopenia, and we have a normal PT and an APTT. So we would.
Other than the other than the von Willebrand disease, are you going to think about any other congenital thrombocytopenias?
Congenital thrombocytopenias. So since he had required plasma transfusions for ovarian cyst removal, and under that covered, if that was the case, then she would have received platelet transfusions.
Okay.
And there's no history as such pointing towards congenital thrombocytopenias, in which case she would have required repeated platelet transfusions.
Suppose there was no history of plasma transfusions, what else would you think of? What other diseases would you think of? Would you
in
think
that
of
case, it could be a congenital
thrombocytopenias? Okay, right. Okay,
congenital thrombocytopenia, or it could even be the thrombocytopathies like the Bernard-Solier or the Grandson's thrombocytopenia.
Yeah, the Bernard-Solier, would you get a family history in the mother?
Bernard-Solier is extinct. No, I'm not sure, but I don't think so.
So Bernard-Solier is autosomal recessive. You generally don't get a family history in the parents in Bernard-Solier. You get a family history in autosomal dominant disorders.
Yeah.
And X-linked disorders. So you would, think of some autosomal dominant thrombocytopenias also. Yes.
So von Willebrand disease is an autosomal dominant condition most of the times. So that is also fine.
All right. So yeah, so here we proceeded with the further workup, and you have the platelet count on smear of around 80,000 and a von Willebrand antigen of 71%. And if you have most of your platelet aggregation is normal, ADP is normal, collagen is normal, adrenaline is normal. Do you want to do anything else here?
Deep, you can answer.
Yes, sir. No, sir, I'm not quite sure what they should go ahead after this.
Okay. Anybody wants to answer that? All right. Okay. So, you know, we had two more tests. One is ristocetin cofactor assay, which is 15%, and aggregation with the low dose ristocetin, which showed a good aggregation with the low dose ristocetin. What is expected here in a normal person if you give low dose ristocetin for platelet aggregation? In a normal person, anybody? I would have expected somebody to answer this. It's a very simple question. Very simple question. Hello.
I have unmuted everyone. Anyone can unmute yourself and speak.
Yeah. Okay.
Any raising
Right.
hands also?
So my question is, in a normal person, what do you expect a low dose ristocetin aggregation? Is it normal or absent or decreased? Multiple choice. A, normal. B, decreased. Okay. So in a normal person, you would expect a decreased aggregation with ristocetin. You wouldn't get an aggregation with a low dose. You will get an aggregation with a normal dose ristocetin, right? A low dose ristocetin is not good enough to produce aggregation in a normal person. So here in what is the diagnosis? Ristocetin cofactor is low, 15%. 1 milligram antigen is normal, and you have a low dose aggregation with the ristocetin with a thrombocytopenia. I wanted to ask anybody to discuss this. Somebody can discuss this, it will be good. What is the diagnosis?
Sir, it's von Willebrand type 2B.
Okay, very good. Your good name, madam?
Anila.
Okay, and you're from?
I am from Srijitra, Trivandrum.
Okay, very good. So your diagnosis is absolutely correct. It's a type 2B von Willebrand disease. What are the points in favor? How did you arrive at a diagnosis?
Because of the low dose ristocetin activity. So the von Willebrand factor is having increased affinity for platelets. So there is a fault. The platelet count is also coming down.
Okay, all right. And why is the von Willebrand antigen normal?
This is platelet type of von Willebrand disease,
Okay.
I think, sir. So
Yeah.
von Willebrand factor is normal, but the platelet has got functional defect.
Yeah, so platelet part of the von Willebrand molecule binding to the platelet may have a functional defect, and the antigen activity, it is a quantitative. Quantitatively, it is normal. The answer is that it's a qualitative defect. Okay, right? So if you go into the von Willebrand disease, you have a type 1 and type 3, which is partial and complete quantitative deficiency, and then the type 2 is a qualitative deficiency. Now here we have a patient with type 2B, which is actually a qualitative variant with increased affinity for the platelet receptor. The other qualitative variants are type 2A, type 2M, and type 2N. Now type 2N is with decreased affinity for factor 8, and the type 2A and M are with decreased affinity for platelet binding, but one with a high molecular weight multimers and one with absent one with absence of high molecular weight multimers and one with the presence of high molecular weight multimers. So yeah, so essentially these are the four subtypes more elaborately described in this cartoon. The increased binding of the platelets to the von Willebrand antigen will cause thrombocytopenia. Okay, right. And before going into the next case, I also wanted to mention that the thrombocytopenia in the von Willebrand type 2B, you will have a, you will need to have a high index of suspicion because it may often present in adulthood. It may not be very evident in the early childhood. So there are patients who may present far into the adulthood with a thrombocytopenia. So it is always very important to ask a family history of any patient who presents with thrombocytopenia, because the type 2B1 disease may be present. Any other differential diagnosis for a very similar picture in the blood tests? Very similar picture in this blood test. And you have any other differential diagnosis? Very similar picture. It may almost sound very similar when you test like this. Anybody? Any volunteers? Okay. So,
Sir, could it be Bernard Solier, sir? Yes.
it may not be Bernard-Solé. What was in my mind was the platelet type von Willebrand disease. The defect here is in the von Willebrand factor, and
Okay.
a similar defect on the platelet surface can produce the platelet type von Willebrand disease. So, sorry. Right. Okay, so we'll move on to the next one. Yeah, Rafi, do we have any volunteer here?
Yeah, we have Dr. Arthur.
Okay, so this is a 63-year-old male, incidentally detected PT prolongation, no history of bleeding, and it's a very simple case, I think. PT of 24.3 seconds, and she has a history of he has a history of coronary artery disease in the past, and he had a PTCA done and has a stent in situ. So
hello, sir.
Yeah, you can introduce yourself. Yeah.
So I am Adira from Jubilee Mission Medical College.
Yeah.
I'm a third year intern, junior resident. So it's a 63-year-old male with incidental detection of PT prolongation. So the history, there is no history of bleeding, and his PT is prolonged, and there is a history of CAD. So this PT prolongation could be due to
yeah. So is it due to a bleeding disorder?
So there is no chance of any bleeding disorder. It most probably due to any drug.
This patient has already undergone a minor invasive procedure with the PTCA. PTCA usually it's an they have a small catheter. It may be a radial also nowadays, but a small catheter inserted. So she has undergone a kind of traumatic procedure and tolerated well without any bleeding symptoms, and has a prolonged PT. So if you think it is not a bleeding disorder, then how would you proceed? Will you say everything is fine, you come back and test after 3 months?
So here PT is prolonged, so it can be due to extrinsic factor deficiency like factor 7, so that can cause PT prolongation like this.
Okay, so what are your differentials for an isolated PT prolongation?
So mainly it can be due to factor 7 deficiency.
Anything else? Anything else?
So liver disorders like liver disease.
Okay. Liver disease, is it always isolated PT prolongation?
No, other factor can also be affected.
APTT can also be prolonged. Usually APTT is also prolonged in liver disease. Sometimes earlier on you can find an isolated PT prolongation. But otherwise you're thinking about a factor 7 extrinsic pathway defect here, isn't it? Okay. So how are you going to
warfarin-induced prolongation?
Warfarin-induced prolongation. Again, will APTT be prolonged in warfarin?
Yes.
APTT can also be prolonged in warfarin. Okay. So, but so how are you going to proceed with your workup here? You're going to go straight into factor 7 analysis?
Yes. So we need to do mixing study.
You need to do mixing study. Okay, very good. Okay, so mixing study, let's see what they've done. Okay, so you have the PT, again repeated the PT, it is even higher, 32 seconds when you repeated the PT. APTT is normal, thrombin time is almost normal, you have the fibrinogen which is normal, and the mixing study shows a very good correction. So what do you do now? Imagine you are working in a center with the best facility where everything is available.
So
Yeah.
factor assay level.
What factors you want to do? You said it
The
already.
factor 7 level.
Okay. That's the
Yeah,
factor 7
that is
level.
reduced.
Okay. So, okay. So factor 7 level is only 6% here. Right. So, again, I am asking you as a clinician, I am asking you, and you will face this after you become a consultant. Clinicians will ask you a question: why is the patient not bleeding in the past? Why did he tolerate coronary angiogram where he was fogged and his factor level is only 6%? And how did he tolerate the procedure? And why there was no other symptoms so far in his life? He's already 63 years.
So because other factors are compensating for the coagulation, so it won't be like so much bleeding for this patient.
Okay, let us try to look at what are the reported factor 7. There are registries available for factor 7. Factor 7 is a very rare disorder, so the registry data has been compiled, and one of these graphs that you can see I've put is 54% patients have no symptoms. So majority of the patients with factor 7 deficiency are asymptomatic. You may not even know that in the lifetime, you may not even know that you have a disorder. Even small procedures, bleeding after trauma is 17%. Okay, mild spontaneous bleeding, bruising, nosebleeds, abnormal menstrual periods, and all 22%. And only 7% of patients with factor 7 deficiency will have major bleeds, joint bleeds, etc. So that's a surprising thing, isn't it? And if you look at the bleeding symptoms, and if you have to closely monitor the bleeding symptoms and ask for the symptoms, these are the symptoms that you should ask for. Epistaxis is one of the most common symptoms in factor 7 deficiency. Easy bruising, gum bleeding, sometimes muscle hematoma and hemarthrosis can also occur. Now it is, you see, if we have been taught that the factor deficiency usually causes deep bleeds, and easy bruisability, gum bleeding and all can happen in platelet and vessel wall disorders. But if you see, factor 7 probably is an exception, where majority of the patients with factor 7 deficiency may actually present with easy bruisability and gum bleeding and epistaxis. Okay. So how will you treat a factor 7 deficiency patient? Factor 7 is commercially available as a recombinant injection, and there are in many countries a plasma derived factor 7 injection is also available. Now it is the factor 7 injections are primarily used for hemophilia patients with inhibitors. Okay, congenital hemophilia A and congenital hemophilia B inhibitors, you can see that is a main indication. In acquired hemophilia also, we have, we can use factor 7. Surprisingly, in factor 7 deficiency, you require much lower doses of factor 7. It is only, 1/3 the dose, or even 1/6 the dose that we give for hemophilia that is required for congenital factor 7 deficiency. It is also useful, and these are the approved indications, and it's also useful in Glanzmann's thrombasthenia. So let us move on to the next case. Rafi,
Yeah. Any volunteers? Raise your hand, please. Volunteers, please raise your hand. I don't see anyone. So can I pick one?
yeah, I think you should.
Dr. Lavanya Elamaran. Dr. Lavanya, you can unmute yourself.
Okay, so Dr. Lavanya, you can introduce yourself. This is a 17-year-old female who has history of ecchymotic patches since 1 year. There is no other history of any other bleeding site, and there is no menorrhagia, no family history of bleeding, and the screening coagulogram is within normal limits, and blood group is O positive.
Dr. Lavanya, you are muted. Okay, you can unmute yourself and speak.
She may not be there.
Okay, I think she's not ready for it. Dr. Reena Prajapati. Dr. Reena, can you discuss this case? Dr. Reena. Dr. Ruth. Not there. We have to make it interactive, otherwise it would not be useful for any of us. We have again Muhammad Anas Sheikh who is coming forward, but I think we have to give it to someone else also. Please, if Dr. Tania, somebody please do come forward. We have to make it interactive, otherwise it wouldn't be useful.
You shouldn't feel shy. You shouldn't feel shy. This is to encourage you.
Yeah, Dr. Tania has come online.
Good.
Hello, sir.
Hi.
So here the patient is having ecchymotic patches and coagulogram is normal. So it could be a platelet disorder.
Okay, so you're thinking about a platelet disorder, and what are the tests that you want to do?
Or a vaccine. So first, ideally, platelet count should be done.
Okay.
Then if the platelet count is normal, then we have to do the platelet function test like platelet aggregation and ristocetin agglutination test.
Okay. So you have the results. Can you interpret this for us?
So here. So here, ristocetin low dose ristocetin is 0. Platelet counts are peripheral smear eosinophils.
I've
Protein
highlighted
time.
some of the abnormal tests for you. The platelet aggregation, what are the abnormal results? I've highlighted it. And in addition to that,
ADP collagen. So aggregation study is there is defect in the platelet aggregation.
All right. Okay. All right. So apart from that, the peripheral smear, are you worried about the peripheral smear?
It's showing eosinophils.
Yeah. So what do you think? Eosinophils 25% has got any connection with the ecchymotic patches? And this is for the last 1 year only. It is not from a long standing. Do you think it's a inherited disorder that
it may be allergic component.
Okay.
It may be allergic component.
Okay, doctor. Okay.
Hello.
So no, what I wanted to ask is this platelet. You have seen the results. I am all right with that. But the history is there only for 1 year. I am wanting to ask you why the history is only for 1 year. Is it likely to be a congenital disorder?
No, that's more in favor of an acquired disorder.
That is more in looking like an acquired one, no? Because it's only for 1 year. So that is why I am worried. Why is the platelet aggregation showing abnormality in a 17-year-old female, and it is showing a clinically platelet dysfunction is also evident in the sense that chemotic patches, and it's only 1 year duration, and the peripheral smear is showing some eosinophils. So I'm a little worried. Do you have an entity like this? Have you heard of any entity like this? An acquired disorder where the platelet dysfunction is there and the eosinophilia is also there? Am I audible? Hello?
Sir, you are audible.
Yeah. Okay. So is there a possibility? Is there a possibility of any disorder, acquired disorder? Divya was one who answered. No? Tanya, is there any possibility of an acquired disorder?
Tanya, you have muted yourself.
Hello, sir.
Yeah. Any acquired disorder? Okay, I'll try to see.
Sir,
This is you have seen a lot of eosinophilia on this smear, and if you look at the platelets in the lower diagram, it looks like gray platelets.
Okay.
Okay. So what are the acquired causes of platelet dysfunction? So let's try to see what are the acquired causes of platelet dysfunction. Okay. So you can have aspirin, NSAIDs. You can have drugs like adzizimab. You can have clopidogrel, ticlopidine, dipyridamol. And you can have fluoxetine, some antibiotics. Okay.
Okay.
Hello.
So hello, sir.
Yeah. So those are the medications which are commonly known to cause platelet dysfunction, right? We intentionally give aspirin, clopidogrel, etc. to produce platelet dysfunction, right? So probably we need to ask this patient whether she is on any of these drugs. I think we should ask the patient about this drug history. Okay, so chalo, we'll ask the patient. We ask the patient. The patient is 17-year-old and she is not on any of these drugs. The other possibility is, if she has another disease. She has a peripheral smear showing eosinophilia. So two other diseases where platelet dysfunction can happen is uremia and myeloproliferative disorder or myelodysplastic syndrome. But this patient was further evaluated for myelodysplastic syndrome, myeloproliferative disorder, but the review of the peripheral smear didn't show any evidence, and the clinical examination was also not very suspicious of any of these. Okay, the other possibility is when you have a cardiac bypass, just for academic, but not applicable in this particular patient. So what else can happen in this patient? What else can happen in this patient? Sorry. What else can happen in this patient? Have you heard about a condition called acquired platelet dysfunction with eosinophilia? Hello?
No, sir. No, sir.
Okay, so there is a condition called acquired.
Hello?
I am sorry that one of my slides have got missed, but there is a condition called acquired platelet dysfunction with eosinophilia. So you have a patient. This is very commonly encountered in children and adolescents, and particularly when the eosinophil count is quite high on the peripheral blood, you would find the eosinophilia, and if you would find the platelet dysfunction. And what we generally do is to treat the eosinophilia with some deworming and diethyl carbamazine, and subsequently when the eosinophils come down, the platelet aggregation becomes normal. It is more or less a very benign condition, and this we have to keep in mind whenever whether a patient comes with a short history and peripheral eosinophilia. So it is always very important to look at the complete blood smear, and the blood smear itself will give you a lot of information regarding. So it's almost very prototype that the child comes with ecchymotic patches and peripheral eosinophilia. You could more or less consider this diagnosis. Okay.
Okay, sir. Thank you, sir.
Thank you very much. Okay. Now we move on to the fifth case.
We have one volunteer, Dr. Mohammed Fawad Farooq Khan.
Okay, Dr. Mohammed, the case for you is a 64-year-old male. Very interesting case. He came with a subdural hemorrhage, and the neurosurgeon calls up saying that this subdural hemorrhage has been operated once, but it is bleeding again. And he checked the coagulation profile, it is deranged. He wants to go for another bulk hole evaluation. So both the PT and APTT were prolonged, and there is no history of bleeding since childhood and no family history of bleeding. So Dr. Mohammed, are you there?
Fawad Farooq. Mohammed Fawad Farooq, please unmute yourself.
Good afternoon, sir. This is Dr. Fawad. I am a blood bank officer. I'm a blood bank officer at Jain Medical College, Aligarh Muslim University. Actually, I had prompted for the last case 4, where I wanted to say the myeloproliferative disease could be the one of the reason for eosinophilia as well as for the platelet dysfunction. But since now I've been called for case 5, so I would definitely take it up as well. So this is a case of 64-year-old male who has had a history of subdural hemorrhage with deranged coagulation profile, and he has come back now, and again with the history of hemorrhage, and there is a both PT and APTT are deranged, and there is no history of bleeding since childhood, and there is no family history of bleeding. So I would say first that since there is no history of bleeding since childhood and also no family history, so it is something which is acquired disorder. And since both APTT and PT are deranged, so I would say it's a coagulation factor disorder. So most probably I would say it is since patient is.
Yeah, you're right. But I also face the same difficulty. When this patient came, just like you post now, we also post. It is a very real world scenario, because we would have expected an isolated APTT prolongation, thinking that it is an acquired hemophilia, right, Fawad? Yeah.
Right.
Yeah, but the thing is, PT is also prolonged. So what is happening? Let's see what happened. Let's see.
Can it be factor 13?
Okay.
Yeah, so this is the MRI report is there, which is showing the bleed, and these are the values that we got: PT of 21 seconds, APTT of 88 seconds, TT of 18.7, and fibrinogen of 491. So definitely it's a PT APTT prolongation, and APTT is much more prolonged than the PT here, right? And those are the mixing studies correction. What do you think about those corrections values of PT and APTT? Mohammed, are you there?
So yes, sir, I'm there, but sorry, I don't have much experience in these studies because they are not done at my center. So I would not be able to speak much about that.
Sure. Okay, I'll take you through this. So basically, we found these corrections are not good enough. The corrections are not adequate, telling about a factor deficiency. So there's looking like there is an inhibitor there. So we did an inhibitor screen, which is positive. And then we had DRVVT done. DRVVT is positive. He had anti-beta-2 glycoprotein and anti-cardiolipin antibody strongly positive, and he had an ANA test which is positive, and he also had a factor 2 levels of 31%, which is low. Now, can you make a diagnosis?
So it is pointing towards some autoimmune disease.
Okay. So coming back to the coagulation part of the autoimmunity, actually we have to solve the riddle for them. No, why? So the DRVBT is a lupus anticoagulant, right? So the lupus anticoagulant is positive, and that is probably explaining the APTT prolongation, right? APTT prolongation, which is not getting corrected, we are explained by the DRVBT positive. But DRVBT hardly prolongs PT. PT prolongation you don't find. So, but we have a factor 2 deficiency. Factor 2 deficiency can also prolong the PT, right? Right, because it's a common pathway. It's a common pathway. So factor 2 deficiency. What is factor 2? What is factor 2?
Prothrombin.
Okay, very good. So this is a unique condition, and this condition is called as, anybody can tell about the full diagnosis of this condition? It is LAHPS. What is LAHPS? Lupus anticoagulant hypoprothrombemia syndrome. All right, can you follow me? Lupus anticoagulant hypoprothrombemia syndrome. Right. So sorry, lupus anticoagulant hypoprothrombemia syndrome is in a patient with lupus anticoagulant, you would expect a clotting, bleeding, hyper thrombotic stage, but in a hypoprothrombemia you can expect bleeding also, because there is a specific lupus antibody against prothrombin. So you have a lupus anticoagulant and you have a hypoprothrombemia. All right, are you following me?
Right, sir.
Yeah.
Yes, sir.
Yeah, so you know what, this patient was started on steroids because it is an autoimmune condition, and his coagulation parameters improved, but later on he developed a myocardial infarction also because of the strong positive. So now he is on anticoagulant also, anticoagulation. So he's on. So basically, this is a condition which is predisposed to both bleeding as well as clotting between, the two horns of a dilemma. Okay. Any doubts on this? Any doubts on this before I proceed?
Sir, then it is very difficult to manage, sir, such patients.
Yeah, so it is difficult to balance. So this is but real life situations are always sometimes very difficult to balance. So this is one of those very, very difficult cases. Thank you very much. All right.
Thank you, sir.
Yeah, so let us just try to look at what are the other inhibitors that we see. Inhibitors are generally classified into one which causes hemorrhage, which includes mainly factor 8 and factor 9, and there are other factor inhibitors also rarely seen. 1 milligram antigen inhibitors are there. Then you have inhibitors against fibrinogen. Then you have heparin like anticoagulants. Then some inhibitors like anti to factor 5 can variably associated with hemorrhage, and usually that is not associated with hemorrhage is lupus anticoagulant. Again, here with the exception of what association with hyperprothrombemia, which was there in our case, and of course anti factor 12 also will not cause a hemorrhage. Okay, now moving on to the sixth case.
So next we have one volunteer, Dr. Gayatri AM. Can you unmute yourself?
Okay, so Dr. Gayatri, so we have a 10-year-old male who had epistaxis since childhood, required PRBC transfusion due to blood loss, and history of increased bleeding during the dental extractions at 6 years of age, and no family history of bleeding. That's a very simple case.
Am I audible, sir?
Yes, Dr. Gayatri.
Hello, sir.
Yes, Dr. Gayatri, please go ahead. Is
Hello,
it an
sir.
inherited or an acquired disorder? Inherited or an acquired disorder?
Sir, from the history, like 10-year-old child, sir. So I think it's an inherited disorder.
Okay. And what are
Hello,
your
sir.
guesses? What are your guesses? What sort of an inherited disorder are we likely to see here?
Sir, I suspect a hemophilia.
Sorry?
Sir, I suspect it as a hemophilia case, sir.
Hemophilia. Okay. All right. So how do you want to proceed with your workup?
Sir, can I have the PT, APTT values and all, another CBC if I...
You have your values here.
Yes, sir. Platelet count 4 lakhs, PT 13.8, APTT. Yes, sir. APTT is on the higher side, sir. And bone Willebrand antigen, that time was normal. Fibrinogen is normal. So I suspect it is hemophilia only, sir.
Hemophilia only. Okay. So, okay. What do you think about the clot retraction? Have you done a clot retraction test?
Oh, okay, sir. Yes, sir. Close. Yes, sir. Close. Clot retraction is also abnormal. Okay.
So what does that tell us? Is it
Sir, can it be okay? Factor 13.
what is the classic
Hello.
condition in clot retraction is abnormal? Classical
Sir,
classical
factor sir, factor 13 deficiency.
No. Okay. This is the platelet aggregation results. When the clot retraction was abnormal, we proceeded with the platelet aggregation, and that is what you see, the platelet aggregation results. There is some aggregation with ristocetin, and there is almost no aggregation with any other agonists. What is the diagnosis? Anybody else also wants to add on? You can add on, but see, anybody else wants to add on?
People have answered in the chat box.
Okay.
Mohammad Anas Sheikh has told GT, Glanzmann thrombocythemia.
Okay.
Anyone
So
else?
okay, so he's answered it right. So you know, Glanzmann's thrombocythemia, we will have a normal platelet count. There is nothing from the peripheral smear that you will tell you that it's a bleeding disorder. Your PT and FTT will be unremarkable. And you know, if you have a clot retraction test, that may tell you that it is abnormal. Otherwise, it's going to be a confirmatory diagnosis with a platelet aggregation test, where the only aggregation will happen with the ristocetin, but rest aggregation will not be there. So that is Glanzmann's thrombocythemia for you. And see, if you have the, you know, there are different disorders. You can see that in the Glanzmann's thrombocythemia, you can see that, you know, the GP2B3A receptor is the abnormality lies here, and in Bernard-Sollier, it is between the binding of the two platelets. You know, this receptor actually binds two platelets with the help of a fibrinogen. So that is why the clot retraction is abnormal. Clot will not retract properly because this bonding is not going to happen. Whereas the deficiency in Bernard-Sollier syndrome is at the GP1B receptor, where it is binding to the von Willebrand factor near the endothelium. All right. Okay, the next case.
I have one hand raised, Dr. Saurabh Lahare.
Okay. So, Dr. Saurabh, yeah.
Sir, I was also going to tell it's Glanzmann's thrombocythemia only. So no further comments from my side.
Okay, you can answer this question. Thank you very much. This is a very interesting case. 28-year-old male, and he presented with history of frothing of urine since 2 weeks. And you know, the clinical suspicion was that you know, there is a suspected Alport syndrome. Alport syndrome. So there was a proteinuria, suspicion of an Alport syndrome in view of a mild sensory neural hearing loss, and there was a renal biopsy planned, and then the renal biopsy was deferred in view of a thrombocytopenia. Now there was a history of similar thrombocytopenia, hematuria, and sensory neural hearing loss in mother and brother.
Mm, Sir, mm, I don't have. I need to think. I haven't. I'm not coming on to any conclusion.
Okay, no problem. Let us. You think it is a very in terms of whether it's a bleeding disorder, thrombocytopenia is there, so, but there is also a strong family history. So, what do you think? Do you think it's an ITP or a hereditary thrombocytopenia? That is all I am asking.
Acha, just a minute, sir.
Okay.
Mm,
Is it ITP or a hereditary thrombocytopenia?
mm, I don't think, sir, it's hereditary thrombocytopenia.
You don't. Okay. Anybody with a difference of opinion? Anybody thinks it's hereditary thrombocytopenia? All right.
I've unmuted. Anybody can. Any answers?
Come on, I think I expect more participation in this case. It's a very, very interesting case.
We have around 60 people
Epstein
online as of
syndrome.
now.
Epstein syndrome.
Yeah, Dr. Sunanda, she was talking. Dr. Sunanda?
Yes, Dr. Sananda, please. Do you
Epstein
think it's a
syndrome.
yeah. Sorry?
What? Sir, Epstein's.
Okay, so you think it's an inherited thrombocytopenia, right? My question is it an inherited or an acquired? You think it's an inherited? Dr. Sunanda, you think it's an inherited? Hello? Hello?
Dr. Sunanda, please to reply.
Inherited, sir.
Okay, so I have some more information for you. Your mean platelet volume is 24.31. What do you think about that? And a total platelet count of 1,29,000.
In the comment box, people are saying it is Epstein syndrome.
Okay.
Some are saying it
Yes.
is macrothrombocytopenia.
Yes, sir.
Okay.
Because Epstein is inherited, like similar to Alport's also, like presence with similar hearing loss and hematuria is there.
Yeah, so there was a whole exome sequencing done for this patient, and a mutation in MOH9 was identified. And as you have rightly said, there are a group of MOH9 related thrombocytopenia syndromes, which include May-Heglin, Fechner, Sebastian syndrome, and Epstein syndrome. Okay, the gene is located in chromosome 22, and this gene encodes a protein which is expressed in platelets, kidney, leukocyte, and the cochlea. So it can present to a nephrologist, or it can present to an ENT surgeon, or this patient can present to hematologist. So sometimes we may be very much mistaken as regarding the patient's diagnosis. So you can see here that if you look at the Epstein's, you have the very high possibility that it may be Epstein's, because you have a macrothrombocytopenia. There was no inclusion bodies. There was hearing loss, and nephritis in this patient. So I think whoever mentioned Epstein's need a big applause. Who mentioned Epstein's? Rafi?
Yeah, the names just tell you.
Yeah. So The
Shadakshi Jindal and Dilna Edison.
okay, I think
Two
with
people have told.
yeah, excellent. I think those are really very impressive. We'll move on to the next case.
Volunteers, please raise your hand. Otherwise, I'll be forced to select one of you. Please raise your hand if anybody is willing.
Epstein syndrome.
Otherwise, I'll be selecting Abhiniti Srivastava. Abhiniti, Dr. Abhiniti Srivastava. Kindly unmute yourself.
Okay.
Anyone else? Dr. Anila?
Sir, can you hear me?
Yes. You're Dr. Anila?
Yes, sir.
Yeah, Dr. Anila, so this is, I will quickly mention this. Thank you for volunteering. So 73-year-old male, very small history only given to us. He has a right urinary calculus and he came to the urology for a DJ stenting. So before the DJ stenting, they did the preoperative evaluation and then the PT-FTT was prolonged. How do you want to evaluate? What are your differential diagnosis and how do you want to evaluate?
Sir, it's a 73-year-old male, whether he can have a liver dysfunction where 2, 7, 9, 10 can be deficient, so that both PT and APTT is prolonged.
Okay, very good. So how are you going to evaluate this patient?
So his liver function also has to be assessed.
Okay. In addition, yeah.
Then we can have a complete coagulogram with platelet count also.
Okay.
Then factor assay.
Okay, you have these results. You want to interpret the results and tell us. You have a PT of 90 seconds, APTT of 78.7 seconds. Fibrinogen is normal, D-dimer is normal. Mixing studies are correcting, and there you have the factor assays, and I have highlighted the low factors which you have mentioned.
And so sir, it is like 2, 7, 9, 10 is absent, sir.
Yeah.
So these are vitamin K dependent factors.
Okay. All right. So
and it's getting well corrected in the correction mixing study also. So no inhibitors are there.
So very good, excellent. So I wanted your help in telling about this slide also to the audience, because I thought I will just briefly discuss this slide also, where you have a PT and APTT prolongation. The latter part of this slide, where we discussed the PT isolated APTT prolongation before. We discussed the isolated PT prolongation, and now you have the PT and APTT prolongation. Okay, now do you agree with the slide that coagulation mixing studies there corrects for if it's a warfarin effect, it's a DIC, chronic liver disease, if it's an individual factor deficiency of 2, 5, 10 and fibrinogen, and in a vitamin K deficiency, and it doesn't correct in a heparin and if you have a factor 2 inhibitors. Do you agree with that?
Yes, sir.
Okay, so this person also, another scenario is that the liver disease is spot on. Another scenario is that this patient could be on warfarin. Another possibility is that this patient may be on warfarin.
Okay, sir. Vitamin K antagonist.
Yeah. So because you have the 2, 7, 9, 10 alone prolonged. Have any of you seen a congenital vitamin K deficiency?
No, sir. I've not seen yet.
Okay. So you see the 2, 7, 9, 10 are in different areas, right? You have the 2 here, common pathway, 10 is also in the common pathway, 7 is in the extrinsic and 9 is in the intrinsic pathway. So you have both the PT and FTT being prolonged. What will happen to the thrombin time? Thrombin time is normal, right? Thrombin time is normal.
Is normal, sir.
Yeah. Yeah, usually thrombin time is normal in the study. Here also the thrombin time was normal. Okay, right. So, but thrombin time is abnormal only if the you have the fibrinogen deficiencies. You have the functional deficiencies, congenital deficiencies, or acquired deficiencies of fibrinogen, and some anticoagulants like pyridine and ergotropan can cause the thrombin time prolongation. Just we will go back to the vitamin K. If there is a congenital, there are two types of congenital vitamin K dependent factor deficiencies. One is associated with the mutations in the glutamyl carboxylase gene, and then the other from the vitamin K epoxide reductase gene. So these disorders are quite difficult to treat if it is a congenital vitamin K deficiency, because they usually require supraphysiological doses of vitamin K to correct these. All right. Yeah. Thank you, Dr. Angela.
Thank you, sir. Thank you so much.
Yeah. So we'll move on to the last two cases. The last one was case while Rafi selects a volunteer, I'll just briefly mention this 36-year-old male with a history of skin bleeds and gum bleed on trivial trauma, born of a consanguineous marriage, history of bleeding disorder in sister.
Any volunteers, please raise your hand. We still have our enthusiastic Dr. Muhammad Anas Sheikh still raising his hand. Anybody else? Dr. Dilna, we expect to get to know more about you. You have given a very nice answer. Dr. Dilna Edison, kindly unmute yourself. Dilna Edison. Dr. Dilna, you can unmute yourself and talk. Dr. Deepak Jyoti. Please be part of the discussion. Dr. Deepak Jyoti.
Yes, sir. Good afternoon, sir.
Yeah.
Yes, Dr.
Hello.
Yeah, Dr. Deepak, go ahead.
Yes, sir.
Yeah, so 36-year-old male with a bleeding disorder in sister and history of skin bleeds and gum bleeds on trivial trauma. Bleeding disorder, not bleeding disorder.
Bleeding disorder.
Bleeding disorder.
Okay.
Congenital, acquired.
Congenital.
Okay, very good. So how do you evaluate this? You want the values?
Bleeding. Sir?
You want the,
Yes,
want the values?
Yes, sir. Values. I'll go for the coagulation test.
Okay, we are running short of time, so I'll quickly hurry into the values. Okay, you have a FTT, FTT of 69 seconds. All others were normal. A mixing study is complete correction of FTT, and you have von Willebrand antigen of 0. What is the diagnosis?
Von Willebrand.
What is the diagnosis? Von Willebrand?
Von Willebrand.
What type of von Willebrand? What likely to be what type? We discussed type 2B. Quantitative.
Yes, yes, sir.
Mild or severe? Type 3. Okay, likely to be type 3 von Willebrand disease.
Yes.
Now my question is hereditary or acquired? Again, you said hereditary, but 36 years of age, would you think about acquired causes of von Willebrand disease? Now I have put some acquired causes of, no, don't worry about it. We'll go through this together. See, you have many acquired, acquired causes of von Willebrand disease. You can see the cardiovascular, if you have a cardiovascular disorder with a, flow-related problem, which requires surgical repair, that can cause acquired von Willebrand disease, especially in earlier on in life. Then you will have you can have myeloproliferative disorders, classical being essential thrombocythemia with a high platelet count, producing acquired von Willebrand disease. Then you can have lymphoproliferative disorders or myelomas or other malignancies. You can also have some, high plasma protein like monoclonal gammopathy of uncertain, undetermined significance, which can produce acquired von Willebrand disease. Many autoimmune disorders with antibodies against von Willebrand factor can produce acquired von Willebrand disease, and sometimes hypothyroidism can also cause acquired von Willebrand disease. So intention is that, sometimes if you find von Willebrand disease diagnosed in the adulthood, always, alert the clinician to look for a secondary cause, because sometimes we may think that when you find a low value of von Willebrand antigen, we may be forced to think that it's a congenital, but there are so many disorders where we could which could cause a secondary von Willebrand disease. So some of these acquired disorders, the treatment is also different. For example, you may have to do a plasmapheresis, immunoglobulin, recombinant factor 7, etc., in addition to whatever is regularly given for a congenital. So basically, for a congenital von Willebrand disease, you can give DDAVP or a von Willebrand concentrate. All right. Is it clear? So what I wanted to convey is that you have to look for acquired von Willebrand disease whenever you diagnose von Willebrand low antigen in adulthood. This particular patient, we didn't find any acquired reason, and this particular patient had a family history, and he was a severe von Willebrand disease, but largely asymptomatic prior to the present episode, with a minor symptoms only. So for the circumcision, would you manage with DDAVP or von Willebrand factor? You can look at this table and tell. For the circumcision, would you give DDAVP with tranexamic acid, or would you advise von Willebrand factor?
DD.
Are you sure? So basically, when the I think here, I would certainly use von Willebrand factor, primarily because it's a type 3 disease, and very bad responses usually we get for type 3 with DDAVP. So, and also it is a significant surgical bleeding can occur if it is not adequately adequate hemostasis is not obtained in a circumcision. So here I would definitely give von Willebrand factor and tranexamic acid as against DDAVP. Okay. Any questions? Yeah. Thank you very much. Any questions on this case? Okay. So we have 7 minutes more. I think I'll go to the last question now.
We have Dr. Dilna Edison. She has volunteered.
Okay, so Dr. Dilna, welcome back. So this is a 10-year-old male patient, a small child, basically admitted with atypical pneumonia, and during the admission he developed a deep vein thrombosis in the right common femoral vein, and she was started on Clexane at 0.7 milligram per kg twice daily, and referred to hematology for tailoring of the low molecular weight heparin dose. So how will you tailor the low molecular weight heparin dose?
Dilna, please unmute yourself. Dr. Dilna. Dr. Dilna, please unmute yourself. She had raised her hand. Dr. Dilna.
Okay.
Dr. Keshav Sharma. Dr. Keshav, you're unmuted. You can go ahead. Dr. Keshav. Yeah, you can speak. You're unmuted. Dr. Keshav.
Hello.
Yes, Dr. Keshav, go
Yes,
ahead.
sorry, I don't have any experience in this. I won't be able to. Really sorry.
Okay. Okay, I would appreciate if you can make an attempt on what test you're thinking about in a patient with any anticoagulant. Say, in a patient with warfarin, who is on warfarin, what is the test that you will use to tailor the warfarin dose?
PT INR, that is we usually do.
Okay, very good. So for heparin, somebody is on heparin infusion, what will you do?
APTT, I think.
Okay, how will you keep the APTT? At what level? All right, don't worry about it. So is there any better, my question is there any better test which can be used to monitor, especially heparin, low molecular weight heparin, etc., especially when you're using in children? You know, children, your dose is not very clear. The pharmacokinetics is not very clear as that of an adult. An adult, in a normal weight adult, you don't regularly monitor Clexane. Like Clexane, how many requests have you got for monitoring of Clexane? You hardly receive any requests, right? Right? Hello? Are you there? Kesh?
Dr. Keshav, it's to you.
Dr. Keshav,
No.
are you there? Okay.
Oh, sorry.
Okay. So what is the test that anybody can suggest for low molecular weight heparin? Clexane is the low molecular weight heparin, enoxaparin. So enoxaparin, what is the test used to monitor the efficacy of enoxaparin?
Some have replied as reptilase time.
Okay. Anybody else? Anybody else?
Andy 10A by Dr. Muhammad Anas.
Okay. So
can we use activated clotting time?
okay, Muhammad Anas can speak. He has answered it correctly. So Dr. Muhammad Anas, we started with you, right? We started with Muhammad Anas, right? First question.
Yeah, Muhammad Anas, you can go. You can speak. Anas. I think nobody's ready to speak today.
Good evening, sir.
Okay, yeah, speak up. So you're right. We are excited that you're right. So yeah, so it is anti-10A levels. So anti-10A levels can be used for other uses of anti-10A levels can be for a patient with renal failure, a patient with renal failure, a pediatric patient, a patient with extremes of weight, a obese patient or a pediatric patient, and with a renal dysfunction. And so these are some of the common indications by which where the anti-10A levels is going to. So here we got the anti-10A levels. We found it was subtherapeutic. So we escalated the dose and then repeated the anti-10A levels, and it was normal. And so we continued the anticoagulation till the clot was lysed completely. So the last slide, Mohammed Anas, if you stay with me, is regarding the we have a lot of newer anticoagulants, and a lot of questions you will be getting on what test to use in a newer anticoagulant. So hello, sir. Yes. Okay. So basically, where this is a very simple table which I found useful while preparing for this talk. Whereas if you have a patient on rivaroxaban, and if you want to do a quick test likely to reflect the drug effect, it should be a PT INR. which can, the INR will be prolonged in rivaroxaban effect, and edoxaban also. And for a, these are factor 10 inhibitors, and you could, the best test will be anti-factor 10A level, which is calibrated for this rivaroxaban. But in an urgent situation, sometimes you may still use one that is calibrated for the low molecular weight heparin also. So anti-10A levels and a PTINR go together for rivaroxaban, apixaban, and edoxaban. And for the direct thrombin inhibitor, the initial test,
Dilute thrombin test.
yeah, will be APTT, and the best test would be dilute thrombin test.
Sir.
All right. Okay. So with
Right,
that,
sir.
I think, yeah, thank you very much. And I wanted to thank you all for patiently listening to this and actively interacting with these interesting case scenarios. And before concluding, I wanted to thank all my colleagues here in Amrita, clinical as well as the laboratory colleagues. So these are all live cases, which we had gone through the same difficulties as we went through right now. And I wanted to thank Dr. Sushila Madam for this opportunity, and Dr. Rafi for taking all the pains to organize this. Thank you very much.
Thank you, sir, for this virtual experience. But I think we would prefer the old one because interaction was comparatively less, and we could not pick each person.
Yeah,
so I would like to call Madam also to say a few words.
Okay.
Hello.
Yes,
Dr. Neeraj, thank you so much.
Thank you, madam.
But really missing you. Directly seeing and enjoying your case discussion was much better. But I feel we could do justice to quite a large number of crowd this time.
Yeah,
otherwise
it is,
always restricted to 2024. But now we have around 50. Today we have around now 60 attendees are there already now. So I think the number is very good. And one more thing I thought I would announce that Mohammed Anas, who was the best participant today, will get an Amazon Prime gift voucher of 500 rupees.
Okay.
Okay, so that is today's decision, because he was a very active participant today.
Very much.
Thanks a lot, ma'am. Thank you.
Okay, thanks, Neeraj. Thanks a lot.
Thank you very much.
We will be having ma'am's presentation. It will be an automation in coagulation. I hope the screen is visible, and all over to you, madam.
Good evening, and welcome to the last talk of today. After an interesting session with interesting of Dr. Neeraj, I think I'll be a little boring. Automation in coagulation lab. I thought I'll not just stick to coagulation because there are many pathologists, and overall I will give an overview about automation in the lab and a little on automation in the coagulation lab. So this is an old-time lab where you see so many people working, and for the number of tests you're going to do now, if you take a test menu in a lab, it goes to thousands. There are so many tests coming up each day. So you cannot just work on a manual method for all the tests that you're doing now. So that was why slowly not only in healthcare setup, in every industry, automation is in. And now you see that all of us have now gone on online mode of classes, presentations, etc. So here I'm comparing an old lab and a new lab. I'm comparing you can see an old lab and a new lab. And for that, now here you can see this is our old chemistry lab in Jubilee Mission, and this is the new lab, and this is again the old lab and the new lab. So there is a lot of difference between a completely or a totally automated system and the older manual methods of doing the test. Now, what is automation? How do you define automation? It is the process whereby an automated instrument performs many tests with minimal involvement of an analyst by mechanical or electronic device without human involvement. So you can do I think a biochemistry lab can be managed by just one or two persons on a shift, where you can do up to 2,000, 3,000 tests or even more without adding more number of skilled personnel. Now, sometimes I tell that many labs, they put up a board, fully automated lab. And when you go inside, you see that they have a computer a printer which prints like a computer and a printer. And the instruments, maybe they have a few auto analyzers, but does that mean that it is an automated lab? To have an automated lab, there are many components. You need the hardware and you need a very good software. So in a healthcare setting, you first have the hospital information system, or the HIS. And the HIS has two different branches. One goes for the information system for patient care, and the other is the managerial information system, which we will not talk. We will talk on the information system for patient care. And in patient care, you have patient management system, clinical information system, and the systems for clinical support services. So the clinical and all these data, the data retrieved from the patient management system, clinical information system, and the system for clinical support services is stored in the patient information data system, which is the electronic medical record. So when you're working in the lab, you need a very good lab information system, and that has to get connected to the hospital information system. So I think in my first lecture, I had talked about pre-analytical variables or errors that can happen. And to manage all these, many of the pre-analytical errors, the best thing is to have a very good hospital information system and a laboratory information system in place. Now, why should you automate? What is the necessity to automate? Do all labs need to be automated? I don't think all labs need to be automated. We have to think, do we need to make the workflow easier, or are we having a lot of errors? Are we having more number of specimens, more than what we can handle? And taking all this into account, so we have to automate to ease the workflow, to eliminate errors, to decrease turnaround time, to eliminate biohazards and increase the safety, and to optimize the cost, especially turnaround time. Before we went for a full automation, our clinicians, one of our clinicians asked me, "Madam, do you really do urine testing for the urine sample, or you just, when somebody asks for a result, you write and give?" Because we were not automated at that time. We used to write in the register, and once they ask for the result, we used to give. So when you do like that, the trust is lost. Clinicians' trust is lost. So for all that, we have to think whether we should automate or not. We need clinicians' trust. We need patients' trust. We need to give the right result to the right patient in the right time. Now, problems that existed. So what was the problems that I will talk from my own experience? What is the problem that existed for me before automation? we were unable to handle the increased number of workload. We had approximately 1,400 to 1,500 patients coming in every day for lab testing. So, and most of these tests, as you increase the number of tests, each test has a number of steps, like especially when you're working in biochemistry, you have a lot of tests that take a lot of step, and one person doing it is very difficult. And you have to attain accuracy, as I told you, reliability and reproducibility of all the results. And there is also complication in record management. You cannot just dig your register or go through pages to write the result and to dispatch the result. It has to have a lot of manpower, and a lot of errors occur because of too many cooks usually spoil the soup. And there is an increase in cost per test. Now, so now all these things are for automation in any lab. What are the advantages of automation? A wide range of tests can be performed at a time on the same instrument. So when you have a fully automated system where the HIS, LIS is properly connected, you just drop the sample in the instrument. So, and many of the instruments, they do cap piercing or they remove the cap automatically. So you are taking you're safeguarding the safety of the patient, the staff also. You're careful with your healthcare workers, especially in times of COVID like this. Now, method of automated analysis are accurate, precise, sensitive, and specific. So you need, for a test result, you need the test to be accurate. There should be precision for your instrument, and the test should be sensitive. Now, it should be cost effective. You cannot run a lab ending up at loss. So you have to be cost effective. And this saves labor and time. Work and time is safeguarded. Now, whenever you are having an automated instrument, the incubation and the analysis time is perfectly set in the instrument. So you are not managing the incubation or the analysis time. And the patient and the QC data management facility is provided in the instruments. And what happens if your QC is failed? If you have put a command in the instrument that once QC is failed, you cannot run today's test, you cannot go forward unless you check what is the problem with your QC, you rerun the QC, or you change the lot of the QC, or you recalibrate. Only then you can do that particular test. And even in kinetic assays, where you enzyme based assays, when there is a curve verification, the instrument automatically does the curve verification. And if you have take for example, you have a test and you have different methods of or different principles of doing the test. You can do that on the instrument. Again, you can do sugar with hexokinase, you can do sugar with GOD, POD. It can be done on the same instrument. And you can run more samples with a shorter turnaround time. You can maximize efficiency, minimize errors by integrating mechanical, electronic, and informatic tools to perform an ever-expanding variety of laboratory tasks. So this is very important. You are reducing the error, you are increasing your efficiency. And for us, what has happened is, following the installation of automation, we have reduced our error by, the error rate has been reduced for more than 70% reduction in the error rate, and turnaround and the staff time per specimen collection is reduced to 10%. And patient safety is increased by an average of 50% reduction in the turnaround time, especially in our setup, like in Kerala. Most of the patients, they like to come to the hospital, see the doctor, do the test, take the result back to the doctor, write a prescription for the medicine and go home, because transportation is a big issue. And if you are able to give a test result within the shortest turnaround time, it will be a blessing for the patient and the patient's relatives. So as far as possible, we are trying to have a turnaround time of 2 to 2.5 hours in most of the commonly done tests. what automated and what does it do? What is the mechanism by which analyzers perform? Like whatever we are doing manually, the instrument is doing by automation, like pipetting. When we are asked to pipette 10 microliter, do we pipette 10 microliter or lesser than 10 or more than 10? So that accuracy of pipetting is there. Transportation, so transporting the specimen from one place to another. If you are using the that happens when it is in the what you call that, the fully total lab automation. And even dispensing, like dispensing reagent, dispensing sample, everything occurs in the proper way. And even probe washing, when you are not changing the tips in the probe, the washing in each instrument is done in a very perfect manner, so that there is no carryover from the previous sample or previous reagent. And mixing sample with the reagent, again they have a system for mixing it. Measurement, it is not observer dependent, it is done by the mechanical calculation of the measurement and interpretation of the results. And if your hospital software is good, it can be stored, it can be stored for years in the system or in the backup, and you can generate reports in time. Then same thing in clinical chemistry or in any other this thing, you can have even in hematology, you can have random access or continuous loading. Like you have ELISA is a batch analyzer, whereas you have other analyzers like CLIA is a random access analyzer. ELISA you can do only in batches. It will not be cost effective if you're going to run 2 samples at a time. But whereas in CLIA, it's a random access analyzer which can run samples as and when it comes. And precision for pipetting of low volume samples. Like nowadays in most of the analyzers, the volume of sample pipetted is only 10 microliter. So pipetting 10 microliter to the best precision is done in automation. And temperature control also. So your water bath, if you're going to do it manually, your water bath has to be proper. You have to fix your water bath at 37. It should not go higher, it should not go lower. Whereas in automated analyzers, the onboard temperature control is perfect. It will not work if your temperature is out of control. Consumption of reagent is also lower in automated equipments. So you have a self-monitoring mechanism of, and you have self-monitoring mechanism, and the optics are self-monitored by the equipment itself. And if ever the value is high, the sample will be repeated with auto dilution. And most of the chemistry analyzers come with reusable cuvettes, less water consumption, and they simplify the formats and data storage. Now let's go to coagulation test for coagulation. What are the different methods by which you can do? Manual method, semi-automated analyzer, and automated analyzer. Manual method in coagulation, like you have manually, all the tests, if you had come for the cascade, you would have done all the tests manually, because in cascade we encourage the participants to do test manually. So platelet count, PT, APTT, mixing studies, and then mixing studies, inhibitor assay, and even the Bethesda assay is done manually. We try to make them do it manually. So manual method is being done. But what happens, manual method is very time consuming. The accuracy is not as good unless you are full time doing the same test. You will get a perfect result when a person continuously does only one test. So he excels in that testing methodology. So that is one disadvantage in present situation where there is frequent change of our staffs. So semi-automated method again is half good but not so good. You have the pipetting done manually, the heat block is in the instrument, so that is okay. But automated instrument, like any other automated instrument, has all the advantages. Now we can compare all the three methods of testing. manual, semi-automated and automated. In manual, all the reagents and samples are added manually by the operator. In semi-automated, all reagents and samples are added manually by the operator. Automated, all reagents are automatically and samples are automatically pipetted by the instrument. The temperature is maintained by a water bath or a heat block in manual method. In semi-automated, again, it contains a device for maintaining a constant temperature. That heat block is the added advantage that the semi-automated analyzer has. And automated contains monitoring devices and internal mechanism to maintain and monitor constant 37 degrees temperature throughout the testing sequence. And the best thing of automated analyzers are, even if the ambient temperature goes high, the instrument will stop working. So we don't have to tell don't work. The instrument by itself will stop. Now, in manual method, it may require external measurement by the operator, most often using a stopwatch. This is the most critical point, because in a coagulation test, you have to stop as soon as you see the clot, or the first appearance of clot, you have to stop. That will differ for me. For any observer to observer, there is a difference. Even you repeat it twice, it may not be the same value. So that is a very what do you call that, operator subjective test. So the operator again has to be very experienced in doing the test. Now, semi-automated has a mechanism to automatically initiate timing devices upon addition of final reagent and internal mechanism for detecting clot formation. In automated, timers are initiated and clot formation is automatically detected. Now, the methods are based on endpoint detection, or everything is an endpoint detection. One, you have mechanical; two, optical; photo-optical, which is nephelometric, chromogenic or immunologic; and electrochemical. Mechanical, electromechanical, or the impedance method, where there is a magnetic ball method, where a ball rotates in, and as soon as the clot is formed, the ball stops rotating. Now, electromechanical method, where it is mechanical and there is an electrical impedance is there, which is conducted and read, like concentration of the clotting factor, which are charges, and the inorganic ions will change when coagulation process takes place. So and along with this, the impedance or conductance is changed. So there are two probes moving in and out of the solution. When the clot forms, the two probes maintain electrical contact. When the probe leaves the solution, the timer stops. So it is when the clot forms, there is an electrical contact between the two probes. Now, photo-optical method is measuring the optical density. So when a clot is formed, there is a change in the optical density of the test sample. And this is the basis of all photo-optical instrumentation. And here, this is known as a turbidometric methodology. So there's a light source, and it is passed through a test solution, that is plasma. And the light goes out of the test tube and is detected by a photo detector or a photo cell, which is located on the other side of the solution. And the amount of light that is detected is dependent on the color and the clarity of the plasma sample, and is considered to be the baseline light transmission value. So when there is a fibrin clot, or when the plasma starts to clot, the fibrin strands, they cause light to scatter, allowing less light to fall on the photodetector. So the plasma becomes more opaque. Like you see here, you'll find that the plasma is more opaque, and the amount of light that is transmitted is very less here. So the optical density, so this change in optical density triggers the timer to stop. Now, the other method is nephelometry, which is based on plasma proteins. Plasma proteins are measured based on the specific reaction. The protein is measured with highly specific antisera. So the protein reacts with highly specific antisera, and the precipitants form antigen antibody complexes, which show up in the solution as turbidity, and they scatter the incident light. So here, nephelometry, when you're measuring any test for plasma protein, the best methodology is nephelometry, because the scattering of light is detected in two angles. Like you see at 180 degrees and 90 degrees, there's a scatter, both forward and side scatter is there, and that is measured. So that is why nephelometry is more accurate, and and you can find the lowest value. So the method senses decreased light transmission at 180 degrees due to the opaqueness of the sample in aquate when fibrin is formed. Chromogenic assay, they are designed to measure. Nephelometry, fibrinogen is done in nephelometric. It is best to do in nephelometric method also. Chromogenic assay it is designed to measure level or function of specific factors, and this method is based on the use of a specific color producing substance known as a chromophore. And the chromophore that is normally used in the coagulation lab is para-nitroanilin. It is not, this is wrong, para-nitroanilin or PNA, which has an optical absorbance. Now, immunologic method again is based on antigen antibody reaction. All these are antigen antibody reaction, but here latex microparticles are coated with specific antibodies directed against the analyte or the antigen to be measured. A beam of monochromatic light is then passed through the suspension of microlatex particles. When the wavelength of the light is greater than the diameter of the particles in suspension, only a small amount of light will be absorbed through the particles. The increase in light absorbance is proportional to the size of the agglutinates, which in turn is proportional to the antigen level present in the sample, which is read from the standard curve. So all tests are measured on an antigen antibody reaction and the passing of light, whether it be immunologic, photoelectric, photomechanical, everything is based on this reaction. Now, who are the manufacturers for automated coagulometers? One thing I have to tell, when you go for any instrument, be it automated or non-automated, the first thing before buying an instrument, you have to see your need, whether you need such a big instrument for your test, whether you will get good service if they place the instrument here, and cost effectivity of the test also should be taken into account. And the coagulometers available, all these companies, they have different models of coagulometers, from less number of tests per hour to more number of tests per hour. Susmex, Stago, Werfen, Transasia, Horiba, all these are these are some of the manufacturers. I haven't listed all the manufacturers, because I listed all those that is available in Kerala. Now, what are the advantages and disadvantages of the different methods like mechanical, photo-optic, etc.? In mechanical does not measure the transmission of light. So even if the sample is lipemic, hemolyzed, it will not interfere in the result. But disadvantage is you cannot give a graphics of the clot formation, or and so the endpoint may or may not be correct, especially when the your analyte you're going to test is very low. Like you will say more than 180 minutes or more than 3 minutes, or you will not give an exact, you cannot give an exact value. Now, photo optic method, the possibility of graphics on clot formation is there. The optical checks for hemolysis, most of the instruments now comes with an optical check. So in many of the recent analyzers, hemolysis, lipemia, icterus or HIL will not interfere with their optical system. And disadvantage, because some of the analyzers don't have this optical check, lipemia, hemolysis, and bilirubin, or protein increase on some systems. Then some systems may present difficulties with clot detection when using some completely transparent reagents. And very short coagulation period may go undetected owing to delay in initiation of monitoring. Now, nephelometry can measure antigen antibody reactions in proteins present in very small amounts, and but the limit their test menu is not very high, and the cost of reagent is higher than the other methods. Chromogenic method, fully specific assays, it may be easier to do by chromogenic. Additional parameters not suitable for measurement by clot detection may be possible, and you can increase the repertoire of possible test, possible improvement in precisions compared to clot based analysis. But the disadvantage, limited by the instrument's wavelength, requires large test volumes for positive cost benefit ratio, and cost of instrument and reagent is also higher. Immunological, you can automate time consuming test or manual methods, and you can increase the number of possible tests. But disadvantages, they have limited number of tests available by this method, and cost of the instrument and cost of the reagents. Now, when you are going to do, so you're going for automation, you have planned to go for automation, what can you do? You can do a SWOT analysis. SWOT analysis is you measure the strength, the weaknesses, the opportunities, and the threats for going or not going. Now, the strength of automation, the process, you are improving the process, you are improving the quality, there is improvement in standardization, turnaround time is lesser, throughput is higher, high availability, and overall cost. What are the weaknesses? Weaknesses depends on the manufacturer, on the IT. If you don't, as I told you, there is no point in getting a fully automated analyzer when you don't have a good IT in your institution, and you don't get an IT support. Then it's same like you're going to do it manually. You will give the sample, you will take down the results, so transcription error can happen, and there is reduced flexibility. So most of the instruments are it is what you call that, they can use only their reagent, you cannot change their reagent, so there is reduced flexibility. And stat handling, many instruments have stat handling, but that instrument will take its own time, you cannot just go and do it like you're doing manually. Then cost for maintenance is also there, so you have to pay MC every year. Now, opportunities, use of skilled staff for more complex staff. So you can just relocate your staff to other areas where they are needed more. And it is cost saving, reduction of unnecessary task or step, involvement of academic lab staff for support of clinicians, patients on bedside, improvement of interpretation of results, because many of the instruments, they give a flagging, or they give what you call that, a probability like that. Threats, high initial investment cost, over expanding test menu, loss of technical skill. So when you have fully automated instrument, your technicians cannot go and work elsewhere in a smaller setup, because they will not be able to do anything manually. So this is again analytical error versus manual, analytical error in manual and automation. Cleanliness of the reaction or tubes or wells, cleanliness of the tips and pipette handling volume, sample to reagent inadequate mixing, introduction of air bubbles, adverse reaction conditions like temperature, humidity, power, pressure, QC out of acceptable limits, inadequate maintenance, instrument failure. And in short, when you're doing automation, you will have built-in QC monitors, continuous monitor and analysis of the QC data, and it will intervene at the earliest sign of variation. It will validate QC control data with lab seniors and immediate corrective action for outliers and validation. So this is my lab. And this is a fully automated lab where you have a robotic analyzer of Sysmex here and an online analyzer of OCD or Johnson & Johnson. You have a specimen sorter, you have a recapper, and you have an archiving center. So you put the specimen in this analyzer, it will sort and it will transfer the instrument to whichever the tubes to whichever instrument the test has to be done. It will come back and it will recap and it will go to the archiving. So when you want to archive, retrieve a sample, it is very easy. And here you have, so once you load the sample, it will get centrifuged also. Whatever needs to be centrifuged will get centrifuged also. So thank you very much. Any questions? Question കാണില്ല, 4 മണിയായല്ലോ. ഇതിനൊന്നും ക്വസ്റ്റ്യൻ വരത്തില്ല, താഴോട്ട് വെച്ചു.
If any queries, you can raise your hand. I have unmuted yourself. If no queries, we will be stopping for the day. Tomorrow again we have the last day. We have 3 sessions. We'll be starting off with Dr. Chepsi, after which we'll be having Dr. Ajay Gandhi speaking on D-dimer. First talk will be on newer oral anticoagulants, and third talk will be by Dr. Ramesh Bhaskaran sir. He'll be talking on QC of anticoagulation. And congrats to the winners. Today we announced 2 winners for the pre-test, Dr. Veena and Dr. Ruth, and to the best participant for the interactive session by Dr. Neeraj, we have taken Dr. Muhammad Anas Sheikh, and the vouchers have already been sent to their emails. So thank you, and see you tomorrow at 2 p.m. Thank you then. Bye.